Headache in the emergency department. Headaches are among the most frequent complaints seen in emergency departments, accounting for approximately 2.2% of all ED visits. Most of these cases stem from benign causes, such as migraines or tension headaches. However, the potential for a serious underlying condition makes the evaluation of headaches in the ED a critical responsibility. In the ED setting, the primary goal is not to definitively diagnose a specific headache type, such as migraine, tension headache, or cluster headache, but rather to identify and rule out life-threatening causes. This requires a meticulous history and physical examination, guided by an awareness of red flag symptoms. Recognizing the red flags. A headache's characteristics can provide crucial clues to its underlying cause. The following features should prompt further investigation for serious conditions: sudden onset or accelerating pattern, including the thunderclap headache, which reaches maximum intensity immediately, worsening with Valsalva maneuvers, morning awakening, or nighttime symptoms, no prior history of similar headaches or a significantly different headache pattern, age extremes, patients greater than 50 years or 120, or papilledema, jaw claudication, especially in older patients, consider temporal arteritis. Clinical context to consider. The presence of a headache in certain clinical scenarios warrants heightened concern: infection, cancer, or immunosuppression, seizures, syncope, or trauma, altered mental status or systemic symptoms such as fever, stiff neck, or rash, patients with nausea/vomiting or taking anticoagulants, steroids, NSAIDs, or antiplatelet agents. Common causes of headache. While life-threatening causes must be excluded first, several common conditions should remain on your radar: migraine, tension headache, cluster headache, trigeminal neuralgia, TMJ or dental pain, post-lumbar puncture headache, within 48 hours of procedure, post-traumatic or post-concussive headache. Uncontrolled hypertension. Clinical features. A guide to history taking. A detailed history provides the foundation for accurate diagnosis. Use the OPQ-REST framework: onset, provocation/palliation, quality, regions/radiation, severity, timing. Onset: was this the worst headache of the patient's life? Did the headache reach peak severity within 1 hour? Did it occur during exertion or activity? Quality and triggers: any auras, visual changes, or neurological symptoms. Are there identifiable triggers? Location. Occipital: think cerebellar lesion, cervical radiculopathy. Orbital: consider optic neuritis or cavernous sinus. Thrombosis. Facial: suspect sinusitis or carotid artery dissection. Prior history: does the patient have a history of migraines or similar headaches? Are there any patterns of medication overuse, caffeine use, or use of anticoagulants? Physical examination. Key steps. A focused physical exam can help pinpoint the etiology. General appearance. Assess for distress or altered mental status. Hint: inspect for trauma, temporal artery tenderness, greater than 50 years. Perform a fundoscopic exam to detect papilledema or hemorrhages. Check for ocular signs of acute glaucoma, fixed, mid-dilated pupil, or cranial nerve palsies. Suggestive of CVST or IH. Assess for meningismus or Koenig/Brudzinski signs. Neurological exam. Evaluate cranial nerves, strength, sensation, reflexes, and cerebellar function. Targeted diagnostic workup. Laboratory studies. Temporal arteritis. Order ESR. Meningitis. Perform CSF analysis. Carbon monoxide poisoning. Check carboxyhemoglobin levels. Intracranial hemorrhage. Non-contrast CT plus or minus LP. Imaging. Non-contrast CT first line for thunderclap headaches or suspected SH. CTA. Evaluate for aneurysms or vascular dissections. MRI/MRV. Assess for masses or cerebrovenous sinus thrombosis in hypercoagulable patients. Management. Tailoring treatment to the patient, nonspecific headaches, NS or LR1 to 2L. First-line treatment, prochlorperazine, 10 mg intravenous, plus or minus diphenhydramine, 25 to 50 mg intravenous, metoclopramide, 10 mg intravenous, acetaminophen, 325 to 1000 mg PO/intravenous, ketorolac, 10 to 30 mg intravenous, migraine-specific options, sumatriptan, 6 mg SQ, 100 mg PO, or 1 to 2 sprays intranasally. Avoid and CV disease, HTN, pregnancy. Dexamethasone, 10 mg 4 to reduce recurrence risk. Advanced and refractory cases, magnesium sulfate, 1 to 2 g intravenous for acute migraines. Occipital nerve block, useful for cluster headaches or occipital migraines. Ketamine, low dose for severe status migrainosus. Sphenopalatine ganglion block. A simple and effective bedside technique for intractable headache, giant cell arteritis. Prednisone 40 to 100 mg PO/QD. Cluster, O2 by face mask or NRB. Disposition. What comes next? Outpatient follow-up. For recurrent or recalcitrant headaches, refer to primary care or neurology. Admission. Reserved for status migrainosus or dangerous conditions requiring inpatient monitoring. Takeaway message. Headaches may present as a simple complaint, but they demand a nuanced and vigilant approach. By systematically identifying red flags, leveraging clinical skills, and tailoring investigations and management, we can transform this common symptom into an opportunity to provide impactful, potentially life-saving care. Every headache tells a story. Our job is to interpret it carefully. Thank you for joining me on this journey to explore and learn. Your support means the world. If you found this helpful or inspiring, don't forget to like, subscribe, and hit that notification bell so you never miss out on new content. Together, let's keep growing and sharing knowledge. See you in the next one.